Welcome back. It's been a while. Still working on my monster. Um, Something I forgot to mention, but you guys may have noticed, may not have noticed. I skipped chapter 14. It is industrial organizational psychology. It is a very, I'm gonna be very honest, it's a very niche thing. Um, Industrial organizational psychology, it is, has to do a lot with business practices, has to do with, you know, it pertains a lot to business. Um, and that's not necessarily um, what I think a lot of people are here for. Um, I put the thread on Canvas a while ago, asking people why they were here, and from what I saw, I don't really think that this is what people are after. So I'm skipping it. If you have any particular questions on it, by all means, let me know. That is not my field. So with that being said, my the ways I can help you with it are somewhat limited, but I'm happy to. You look at, say you're opening a restaurant, and you want people to be hungry and eat the most food and order the most food off the menu. An industrial organizational psychologist will come in and tell you what color to paint the walls to make everybody hungrier. Um, Same with plate size. If you want people to pay a certain price for food, but you don't want to give them too much, they will pick out plates that are smaller and get people to eat less. And um, like I said, it's kind of very niche. So, um, like I said, I'll help you if you have questions about it. It's just not really my thing. So, by all means, don't let that deter you. I have equal amount of respect for industrial organizational psychologists as I do anyone in the psychological field. Um, it's just not my thing. So it's a little bit harder to relate. Um, we are about to get to the meat and potatoes. We are about to get to my field. Um, don't be scared. Can be very intense though. Talking about psychological disorders. Um, I put in the PowerPoint. Um, I put some stuff in there. Let's see here. Opening it up now. There's a lot of videos. Did I put the videos in here? I can't remember. No, of course not. That would have made way too much. Oh, wait. Oh, I did. Okay, good. There are some videos. There's also a couple articles in there. Um, I have some additional videos that I'll probably put on there as well. So psychological disorders. I gotta get on my high horse for a minute. Excuse me. A set of behavioral, emotional, and/or cognitive symptoms that are significantly distressing or disabling in terms of social functioning, work endeavors, or other aspects of life. Um, Maladaptive behaviors or actions that run counter to what is in one's own best interests. Um, and then abnormal behavior is behavior that is atypical, dysfunctional, or deviant. All right, skip slide 2. Well, no, before you do that, a lot of what's on slide 2 is on slide 3, and we're going to talk about it a little bit more here in a second. Slide 2, what I want you to understand is the definition of insanity. Insanity is a legal term. You will never hear somebody in a mental health setting call someone else insane. I'm willing to bet money. I've never heard it. Okay? And I've been working in this field for a while now. It's a legal term. And we use it to talk about people's level of responsibility and how responsible they are for something. That is not something that we use. Why? Because of the next term on the slide. It's called stigma. It's a negative attitude or opinion about a group of people based on a certain traits or characteristics. We have been fighting for years. When I say we, I mean clinicians and psychologists and counselors and everyone under the moon have been trying to remove some of the stigma from treatment for psychological disorders. Um, and that's one of the reasons why we subscribe to the medical model whenever it comes to treating this. Because we don't want people to be scared to get help. We don't want people to think, oh, well, this person's crazy or this person has demons in their brain or something. No, it's not like that. It's a medical condition. It's just like diabetes or anything else. And that's why we treat it this way, is because we want it to be without that stigma. So, um, now going back to what was on the second slide, but is even more enforced on the third slide. How do you know if something is a psychological disorder? First off, deviance. We tend to know what's normal and what's not normal. Deviance has a negative connotation associated to it. Deviance does not necessarily mean bad or evil or illegal or anything like that. The only thing deviant means is that it's abnormal or it's not typical. Okay? So, the example in the PowerPoint is transvestic fetishism, which I think we talked about before. Matter of fact, I know we have. Is it normal? Absolutely not. Does it hurt anyone? Maybe, maybe not. It depends on the circumstance. Okay. But whenever we talk about these criteria, what I want you to think of is just start associating that word deviant with out of the normal. Another example. Most of the time when you do laundry, you throw it in a washing machine, right? That's your typical way of doing it. Guess what? You don't have to do it that way. You can wash your clothes by hand. Is it deviant? Is it out of the norm? Is it something new? Yes. Does that mean it's bad? Not necessarily. So, deviant. Next is dysfunctional or maladaptive. This is where it serves a purpose, but it's not good for you. And the example listed here is substance abuse. There have been studies, and actually I wish I would have included it in here. Maybe on second thought I will go back and add it. There is a TED Ed video, Everything That You Know About Addiction Is Wrong. And it talks about how people form habits whenever it comes to substance abuse because of their lack of connection to other things in the world. Think about people who don't know how to deal with their problems. So they drink, or they use drugs, or they have promiscuous, unprotected sex. It serves a purpose. They're doing it for a reason. It is an unhealthy way of coping with something, or an unhealthy way of dealing with something. And that's what maladaptive is. It's not going to sustain you. It's going to hurt you more than it helps you. But in the short term, it's your way of dealing with it. And that's dysfunction. And then distress. This is your big one. If the disorder is causing subjective pain. Going back to substance abuse. Do people who are alcoholics or drug addicts, do they think they have a problem? A lot of times the answer is no, they don't think they have a problem. But, and this is where this criteria comes in, they may not think they have a problem. But what will be a problem for them is the strained relationship with the person who brings them in for treatment. So personal distress does not necessarily mean that they don't think it's a problem. Sometimes you have to make them see why it's a problem and make them realize why it's personally distressing. Does that make sense? Hopefully. Wish I could get an answer. Anyway, epidemiology is the study of distribution of mental or physical disorders in a population. So you want to look at how many cases of anxiety are reported per year, or how many cases of Alzheimer's are reported per year. That number is epidemiology, and it's something that's studied. Prevalent is that number in terms of a percentage. And if you look on the next slide, on slide 4, there are rates of psychological disorders. 18.1% of Americans reported anxiety disorders, almost 9% specific phobias, almost 10% mood disorders, 6.7 major depression, and then 3.8 substance abuse. One thing I want you to know, those numbers are probably old. These numbers could be much higher now. I don't know when exactly those were pulled from, but they are older. Diagnosis and classification. Um, so DSM-5 is our Bible. That is what we use to determine mental health diagnoses. Okay. Um, Comorbidity is the co-occurrence of two or more disorders at the same time. People who have depression often have anxiety. People who have depression may oftentimes also abuse substances as a method of self medication. Co occurrence just means that there are two diagnoses at the same time, and it happens a lot more often than we'd like to think. All right, again, stepping up on my high horse for a moment. Excuse me. Um, what I want you to understand, I've talked about stigma a little bit before. Classification of abnormal behavior, this is why this is important. People are not their disorders. And I've had it happen, and I've had it said to me by people professionally and in my personal life. Well, I'm this, so I have this problem. And it's no, no, no. Because what that does is it allows them not to take responsibility for their own actions. It also diminishes hope. They think that this is part of just who they are, and that's not necessarily the case. By talking about people saying, my client with depression, or, my client with, ADHD, whatever it may be, you are recognizing that person as a person still. You are realizing that there is more to them than just the disorder. And I cannot explain to you the amount of hope that that brings, because I've seen it in action. Um, I literally, I made this mistake, I think maybe twice my whole career. And it stuck with me. I thought about it, and it's something that I'm very cognizant of now. Um, so my client with PTSD or my patient with OCD, um, it's important to keep their sense of identity. You also don't want them to use that as a crutch. You want them to take responsibility for their actions, because if they don't take responsibility for their actions, how are they going to change them? And then the medical clinicians and physicians. They have two different methods of classification. I told you that psychologists, therapists, psychiatrists, we use the DSM. For medical professionals, for coding and billing and stuff like that, they use what's called ICD-10. Do you need to know that for the test? No. But I know some of you guys are nurses or looking to be nurses, um, stuff like that. So, all right, anxiety disorders. A class of disorders marked by feelings of excessive apprehension and anxiety or worry. Everyone worries, okay? But that's why I went over the 3Ds. Because sometimes it gets to a point that it's maladaptive. Um, Sometimes we worry so much that it hinders us from doing things that are in our best interests. Um, so, and it can be distressing, absolutely. Um, and that's what anxiety is. Generalized anxiety disorder marked by a chronic high level of anxiety that is not tied to any specific threat. So, it's not a certain animal or a certain situation. It is just general worry all the time about multiple things. It's not tied to one specific thing. Okay? Um, so, what I want you to realize with this is, again, if you have any questions about this, if you're not clear, if you don't understand, go back to the 3Ds. Like, I can't emphasize that enough. Okay? Deviant. Do you worry more than others? Okay? Is the state of worry normal? Because everyone deals with it. Everyone deals with worry all the time. We all have stuff that we deal with. But whether it's a normal amount of worry or excessive, that's something you know the answer to. Um, Maladaptive or dysfunctional? Is it to help you deal with something? We all have a job to do. We have ways that our day is supposed to go. But whenever how that day is supposed to go becomes disrupted because you're busy worrying about whether you turned off the stove or if you turned off your flat iron or, something like that. Or if you're worried about something that could go wrong, if you're worried about, something bad happening to someone in your family, is that normal to worry about? Absolutely. But is it supposed to stop your day? No. And then distressing. You know what's normal. You know what you're comfortable with. You know what you can handle. So, um, phobic disorder is an irrational fear or irrational fear or phobia of an object or a situation that presents no realistic danger. So, I'm gonna go with heights. Let's stick with heights. Is there a reason to be scared of heights? Yes, there is. Absolutely. You could fall and you could die. That is a very real thing. However, is it worry or is it normal or is it helpful for you to worry about falling off of a tall building when you're standing on the street? No. But that happens. Some people will stand at the bottom of a tall building and hyperventilate just seeing how tall the building is and having somebody say, you have to go up there. Can they fall off yet? No, they're still on the ground. But they're so scared of it, even though they haven't gotten in that situation yet, it's a phobia. Okay? Um, Now, if you're hanging off the ledge on tippy toes on point shoes, you know, yeah, absolutely. It's time to be scared then. But there's a big difference between being on the elevator on your way up and then dangling off of a ledge precariously. Um, One presents real danger, the other one does not. Okay? So I hope that distinction is clear. Think about two spiders. Spiders, something to be scared of. Yes, absolutely. There are some out there that can hurt you. Should you stay awake 24 hours a day to make sure a spider never crawls on you? You can't do that. It's not adaptive. It is maladaptive. Um, and is it deviant? Do people stay up 24 hours a day, waiting, trying to keep spiders off of them? No. Not normal at all. And is it a problem? Yes, absolutely, because then you can't do the other things that you need to do in life. Tracking? Hopefully. All right. Panic attack. Panic disorder. I will say this once and only once. A panic attack is not a Kardashian losing an earring in the ocean. I actually saw that somewhere. That Kim has panic attack because she lost an earring, and that was not a panic attack. Okay? Panic attacks feel like very real medical emergencies. You will feel your heart pounding. You will experience a shortness of breath. You will feel like the world is ending or you're going crazy. That is a genuine panic attack. Okay? It's not cute like, you know, Kylie, oh, I can't talk to photographers right now. I'm freaking out. No. Like, this is crying. This is not being able to breathe. This is feeling like you're having a heart attack. It's very, very real. Um, so, um, and that's what that is. Agoraphobia is that you are scared of going out places in public because you're scared of having a panic attack. Agora is marketplace. Agoraphobia is literally fear of the marketplace. Um, PTSD. So, with this, um, this is something to be aware of. So, PTSD has changed in the way that people look at it. It's obviously a much bigger issue, and we talk about it a lot more than we used to. It is also not that you have to have been in life threatening danger. You could have seen someone else in danger or have seen someone else die. And that's PTSD. Um, and people with it, they have flashbacks. Um, and they will withdraw emotionally and avoid emotional experiences, feelings of anxiety, nervousness, excessive arousal. Um, they have what we call higher startle reflex. So they notice sensation and process, um, perceive sensation faster than others. So, their head, that kind of head on a swivel thing, that's a very PTSD type thing. Um, Difficulty with memory and concentration. Because a lot of times a big component of PTSD is repression. They will try not to think about the incident. So they block stuff out. And that's an obvious effect to our memory. And if we voluntarily block some things out, who knows, maybe other things get blocked involuntarily. Impulsive behavior. Um, this is kind of one thing that we kind of look at in terms of suicide. Um, High rates of impulsive behavior are oftentimes associated or correlate very high with impulsive behaviors, not realizing the consequences of one's actions. And this may be the best example of diathesis stress theory, because obviously not every person in a traumatic event has PTSD. So why do some people have it and other people are immune to it? And the slide kind of lists some of the theories about why that is. Obsessive compulsive disorder. Oh, I didn't put this video on here. I'm going to go back and I'm going to add some of the videos, guys, because I'm sorry. I should have done that. So one of the videos, the video that I have, features Howie Mandel. He's the guy from Deal or No Deal. And he has OCD. And a lot of people, there's this common misconception that OCD is this obsession with neatness or order, something like that. That's not true. It's more like if then thinking. Okay? So you have these unwanted, uncontrollable thoughts. So, Howie Mandel, for example, will not touch doorknobs because there's a lot of germs on it. So he will sit there and he will look at a doorknob before he touches it, and he will think about all of the germs that's on it, and he will obsess about it. It's where the obsessive part of this obsessive compulsive disorder comes in. It's all he can think about is those germs and them crawling on him and them getting him sick and things like that. So he has to deal with it. And the way that he deals with it is by avoiding touching the doorknob. Or he will touch it with a piece of clothing. Or he will have someone else open a door. Or he will push, if he can, he will push it open instead of having to touch the doorknob. Okay? And those actions to avoid that thought and those obsessions, the actions that you take to relieve the anxiety from those obsessions, those are your compulsions. Those are your actions. So, an obsession is a thought, an urge, or an image that happens repeatedly, is intrusive and unwelcome, and often causes anxiety and distress. Compulsion is what you do to deal with it. Okay? So, if someone is a germaphobe, a lot of people love to ask me that. Well, is that a phobia or is it OCD? This is why we have the DSM, because you really have to talk to that person and find out. Any way you look at it, it's going to be a problem. It's obviously going to be dysfunctional, it's not normal, and it's probably going to be distressing. Now, which one they meet the criteria for, that depends on how they think. So, a lot of times within an OCD type scenario, they will sit there and maybe they do have to shake someone's hand, or they do have to shake a doorknob, or, touch a doorknob. You have those obsessions. Okay? And all you're going to think about is getting sick from those germs. That's all you're going to do. Those unwanted thoughts, again, are the obsessions. Your compulsions is going to make it OCD. But say that somebody is just scared of germs. Say that they don't have any ritualistic ways of alleviating the anxiety. Then at that point, you may be looking at more of a phobia than obsessive compulsive disorder. That's differential diagnosis. You guys don't have to worry about that. But, that is to say that a lot of these issues you have to be very specific with, and that's why we use the DSM. Okay? Major depressive disorder. People show persistent feelings of sadness and despair and a loss of interest in previous sources of pleasure. This is called anhedonia. Okay? So, a lot of doctors will screen for depression. Um, they're going to be ask you, in the past 2 weeks, have you had feelings of sadness or hopelessness? And they'll ask you how often. Um, have you experienced a decrease in pleasure in things that you used to enjoy? Have you gained or lost weight within the last 2 weeks without trying? Have you been sleeping more than usual or not enough? Feeling tired or drained of energy, having difficulty thinking or concentrating, and then persistent thoughts about death and suicide. These are all big criteria and factors of major depressive disorder. There's been a lot more coming to light about this as of late. Once upon a time, if you didn't get out of bed and you told somebody that you were depressed, they would have thought you were faking it. Well, now people are genuinely beginning to realize the struggle. Um, so, and that's good. That talks about us alleviating that stigma. Um, for depression, you have to have symptoms for at least 2 weeks. Obviously, they have to cause significant stress or impairment, and they cannot be due to medical or drug related conditions. So, if you don't want to get out of bed because you have low blood sugar, that's not necessarily depression. Does that mean you don't have depression? Maybe, maybe not. Again, that's why you go back to the DSM. Sorry. Um, but you have to treat the medical disorder before you can look at the mental health disorder. Hopefully that makes sense. Because maybe you're not really depressed. Maybe you just have low blood sugar. And maybe once you have that medical condition taken care of, the psychological symptoms will go away. So that's major depressive disorder. Bipolar disorder, marked by marked by the experience of depressed and manic periods. All right, so here's the deal. You have manic episodes. This is where you will experience intense levels of energy for an extended period of time. People will be able to run off of decreased sleep, either not sleeping at all or sleeping very little. Um, and those episodes, that energy can be very out of proportion to the setting. Um, and because of that, it's what we call an expansive mood. A lot of times, too, that will manifest in irritability because if you're not sleeping a lot, that affects your mood. Um, but you have very high and sustained levels of energy. You're very excited. You look very happy and very energized. Um, but with bipolar disorder, it only stays like that for so long before you slip into a depressive episode. And that person meets a lot of the criteria for major depressive disorder. That they will not have a lot of energy, that they will not want to get out of bed, that they will have very feelings of downness and sadness. And it's a roller coaster ride and it goes from one to the other. Now, one of the things people like to ask is how often does this happen? Very rarely does this happen in a short period of time. It will cycle. It's a cyclic disorder. And it can be every couple of weeks. It can be every couple of months. It depends on the person. There is a specifier for rapid cycling type in the DSM, and what that does is it says that they have to cycle through so many times within a certain period of time. You don't need to know that, but it's just something that's good to know. A lot of people think that people with bipolar disorder, it's like flipping a light switch. That 1 minute they're happy, and then you just flip the light switch, and then boom, they're depressed. It's not that way. It'll take days or months or weeks. It just depends on the case. Um, Schizophrenia, a disabling psychological disorder that can include delusions, hallucinations, disorganized speech, and abnormal psychomotor behaviors. So, going along with this, psychosis is a loss of contact with reality. So, people not knowing what's real and what's not. This is what I need you to get from this. These next 4 points are really important. So, hallucinations are false sensory information. Seeing things that aren't really there, or hearing things that aren't really there, or seeing things inaccurately, or hearing things inaccurately. Maybe you are trying to have a conversation with somebody, and instead of you saying, you say, "Hey, how are you doing?" They hear the devil's coming for you, and you're like wondering why they're freaking out. It's because you don't know how that sensory information is being manipulated in their brain. Um, so, perceptual experiences that can include that an individual believes is real, but are not evidence to others. One thing is that in fMRI imaging, functional magnetic resonance imaging, you will see that the auditory parts of the brain are active during auditory hallucinations. Their brain genuinely hears and interprets that information, but nobody else can. Um, delusions are false beliefs. Believing I'm the Queen of England and I'm not. Um, Believing that someone is more important than they really are. Um, Strange or false beliefs that a person firmly maintains even when provided evidence to the contrary. Um, Delusions of grandeur, believing that you are someone more important than you are. Delusions of persecution is another one. Believing that the world is against you, believing that people are out to get you, even though, you're being provided with evidence that that's not the case. All right. I need you to wipe your brain for a second. Um, so in the real world, we have this thing that positive is good, negative is bad, right? Need you to wipe that from your mind. Need you to form a whiteboard in your mind and draw a line horizontally across it. Okay? This is baseline functioning. This is getting up in the morning, putting on deodorant, taking a shower, brushing teeth, getting dressed, locking the door, leaving for work, and going about your normal day, however your day looks. That is baseline functioning. Okay? Doing what you have to do to get by. Okay? Now, with schizophrenia, you have positive symptoms and negative symptoms. Positive symptoms are things that people with schizophrenia experience in addition to baseline functioning. Okay? Maybe they can do all of these things. And again, I have a TED Ed video that I'm going to show you. It is a physicist from Penn State University. Astrophysicist. This woman is brilliant. She's, doing all of this work. She was like a scholar before she ever even made it to college. She founded this big star thing. She has schizophrenia. So she wakes up every morning. She goes about her day, but she still has hallucinations. Yeah, it's a thing. And those are positive symptoms. Um, Excessive or distortions of normal behavior, which includes delusions, hallucinations, and disorganized speech. Do normal people with baseline functioning have delusions? No. So that's something that people with schizophrenia have in addition to baseline functioning. Okay? It's something extra. It's something like associated with it. Remember whenever we were talking about conditioning, how positive meant that you added something, right? Now, that something could have been good or bad in order to achieve a behavioral modification, but just the fact that you were adding something made it positive. Same with this. It's something additional. So it's not good or bad. Does it necessarily, are these good? No, not really. But that doesn't make them negative symptoms. This is something that they have in addition to baseline functioning. Okay? So, negative symptoms. Behaviors or characteristics that are limited or absent. Social withdrawal, diminished speech, limited or no emotions, loss of energy, and follow up. So, we have that baseline functioning, these negative symptoms are what keep people with schizophrenia from functioning at that baseline level. So it keeps them from getting up and getting dressed every day and going to work. Um, you know, they can't, maybe they can't show emotion properly. Maybe they can't speak coherently. Um, maybe they can't, you know, function in the outside world. Maybe they can't maintain their hygiene. All of these are negative symptoms. Okay, and this is what keeps them from functioning below baseline level. Okay. Subtypes of schizophrenia. You have paranoid schizophrenia, which is what most people think of whenever they think of schizophrenia. This includes delusions of persecution and delusions of grandeur, which we talked about already. So, very oftentimes there are hallucinations, there are delusions, people are out to get me, things like that. Catatonic. There is muscle rigidity or kind of an ability to hold positions for a very long time. I believe it's called waxy rigidity, if I'm not mistaken. But they can move in certain ways that maybe other people can't. Um, and now with catatonic stupor, that is, catatonic subtype does not necessarily mean that they cannot speak, but oftentimes there will be disturbances in speech. They may stutter or they may use certain words incorrectly, things like that. Disorganized. This is considered one of the more severe. Frequent incoherence, obvious deterioration in adaptive behavior. These are the people who cannot take a shower on their own, who cannot get dressed on their own, um, and that really struggle with functioning in life independently. Dissociative disorders. So, dissociation means a disturbance in identity. Okay? Um, so, a disruption in memory, consciousness, perceptions, or identity. Okay? Um, I really want to focus on the identity part of this because that's really like our big like hallmark thing. Dissociative amnesia is where people may forget things or forget who they are. That they may forget personal information or life events. Um, Dissociative fugue, a condition in which a person with dissociative amnesia wanders about in a confused, unexpected manner. I'm not going to lie to you, neither one of those are going to be on the test. Um, with dissociative identity disorder, it is a psychological disorder that occurs when two or more distinct personalities are within an individual. Now, keep in mind, the videos that are included on here are Dr. Phil. This woman could very well be an actress. This could be complete and total BS. But she played the part well, whether it's real or not. Um, what a big underlying theory behind dissociative disorders is that they are caused by trauma. A lot of times there is abuse or trauma that is comorbid with these disorders. And one of the theories is that the person does not have the resources available to cope with them. So, don't since they can't cope with the situation, they choose to be someone else or that they become someone else as a way of dealing with it. Um and that's kind of one of the big theories with dissociative disorder. Um Sybil, Split, a lot of this is something that the media loves. They eat it up. They really do. Because it's interesting. Who hasn't wanted to be somebody else before? You know, who hasn't wanted to live someone else's life or wondered what it's like to be someone else? It's a natural fascination. But there's certain criteria that has to be met before that happens. Okay. Last but not least, autism spectrum disorders. The book did a really good job of talking about ADHD. and talking about whether it is overdiagnosed or not, treatment for that, things like that. Autism spectrum disorders, a range of neurodevelopmental disorders involving impaired social interactions and communications, repetitive behaviors, and restricted interests. People with autism will oftentimes become obsessed with something. Their interests are very fixated. Um, so when they get into something, it's borderline obsessive a lot of times. A lot of people still think that it has to do with autisms or with vaccines. I'm sorry. One of the reasons why, and something to think about. I'm not saying that that's not a factor in it, but the age of onset is also right about the time the people get the vaccine. So that's kind of one of those things that lead people to think when truly it's more of a cause or more of a correlation. Um, it's a spectrum disorder, which means it's not you have it or you don't. Okay? It is not black or white. It is not flipping a light switch on or off. Um, some people have more of it than others. So there are some very high functioning people with autism um, that it affects their life very little. And for what it does affect their life, sometimes it's actually positive. Because they obsess about certain things, and that becomes their life, and they are able to use that in a very healthy, very productive manner. And then you have some people who, it's just too much. That the level of communication disruption is, you know, very much a boundary, um, and things like that. It just ranges. Um, I did put in there a couple articles on autism. One of these is from a study from last year, I think it was. It's a study by a Korean couple, and they found that it is linked to a bacteria in the mother's digestive system during gestation. Um, so it's definitely worth taking a look into, especially if you know somebody that has autism, if you are planning on having kids one day, it could happen. So the more you know, the better off you are, and the better equipped you are to deal with people in that situation. Um, so, going on along with that, The Good Doctor. It's on Hulu right now. It was on ABC. It shows really well. It's a very good depiction of autism spectrum disorder. So, all right, I've talked to you guys enough for one night. I'm out. I will be online checking things periodically. If you need me, let me know. Otherwise, cheers. Have a great night.